So good morning, everyone. Thank you very much for joining us. What is the morning here, but the evening for our guest speaker, and maybe the afternoon for some of you in other places around the world and the country. For those of you in our virtual room this morning or today who do not know me, my name is Mika, and I am a professor in the School of Population and Public Health at the University of British Columbia, and a member of the leadership team for the school. On behalf of the school, I welcome you to our speaker series, Voices in Health. And at this particular moment, I ask that we take a moment to reflect and to acknowledge, as a University of British Columbia and a School of Population and Public Health event, that many of us gather today to work and to listen and to learn on the beautiful, traditional, ancestral, yet unceded territory of the Musqueam people. I recognize that many of you are joining us from different locations of this virtual world, and ask that you take a moment personally to reflect on the land where you live, work, and play. The land at UBC Point Grey campus is a place that has always been a place of learning for the Musqueam people. And for millennia, they have passed on their culture, history, and traditions from one generation to the next on that land. And we continue that tradition today with our Voices in Health speaker series, an opportunity to learn. And I'm now going to invite Professor Kim McGrail in our School of Population and Public Health to introduce our speaker for this series and our moderator for the session. Kim?
Great. Thank you, Mika. And thanks for all of you for coming today. So as Mika said, I'm Kim McGrail, and I'm a professor in the School of Population and Public Health, and more specifically in the Center for Health Services and Policy Research. So today we're going to have Dr. Lyons speak with us, and then I will provide just a few comments, reflections after his talk, and then we'll have I think plenty of time for your questions and answers. So please feel free. You can raise your hand when it comes time to the questions. You're welcome to use the chat as well. And we'll get through as many of those as we can. So to get underway, I'm really pleased to have this opportunity to introduce Dr. Ronan Lyons. So he's a clinical professor of public health at Swansea University and an honorary consultant in public health with the Public Health Wales NHS Trust, and in the UK, and an adjunct professor as well at Monash University in Australia. The focus of Dr. Lyons' research is the use of routine data in cohorts, trials, and in the evaluation of natural experiments and complex interventions. He's been a leader in a number of developments that are building infrastructure for research using routinely collected data and increasingly other kinds of data as well. So there's more to Ronan's bio, which you can read on our website, but I'd like to add just a couple more personal reflections, because I have the great privilege of knowing Ronan at least a little bit personally. So I had the great privilege of spending part of my sabbatical in 2015 at Swansea University with Ronan and his colleagues. So what I can tell you about Ronan is that he's a highly respected and valued colleague, and really an amazing mentor. And beyond his brilliance, which you'll hear in his talk today, he's funny, kind, generous, and really committed to doing excellent research, as well as helping others do excellent research as well. I think that focus on science and infrastructure is going to be a big focus of this talk today. So with that, it's my great pleasure to turn it over to Dr. Lyons for his talk.
Well, thank you very much, Kim. Hopefully you could all hear me. That was a very nice introduction. I have to get you to do a eulogy at some stage. No, that was really nice, and I'm delighted and honoured that you've asked me to come and give this talk. If I just move on to the next slide. So I thought there we are. So I thought that I'd say a little bit about myself first as well, on top of what you said, and basically what I'll cover. So the biggest point I just want to make here really is that I planned almost none of this, really. Things just happen, and that's the way the world is for most people. So I'm from Dublin in Ireland, and I went to school and did medicine. When I finished school, we don't do graduate entry, we do school direct entry. Why did I do medicine? Well, I didn't really know what to do when I left school. I was 18, typical boy. Well, what do you do now? And I said, that sounds interesting. So I applied, and strangely enough, I managed to get in and had a wonderful time and worked in hospitals for a number of years. And I was working actually in a TB hospital when I met a really good friend of mine, who basically persuaded me that epidemiology and public health was the way. So I went and did that for a while. While I was waiting for a job, I had a friend who was working in Swansea, and I moved to Wales with my family in 1992, intending to stay there just for a year. But actually where we live is really wonderful, and I'm still there. I used to work in emergency departments quite a bit in relation to adults and children, which got me interested in injury prevention and surveillance. And so I did that for quite a number of years. And I've worked for a good while with colleagues in UBC, Mariana Brissoni and Ian Pike, and I'd like to say hello to them. I started off with some data linkage around injuries, and then after a while, then there was an interest in how to expand that. So I wrote a very small grant for £5,000 back in 2006 to set up the concept of creating that. And then that led to the SAIL data bank, which I'll talk a bit more about. I'm involved in quite a lot of UK and international collaborations, and I actually am an accidental academic. I used to work in the health service all the time, but was publishing a lot, and that's when the universities came and kidnapped me to come and work for them, more so than the health service. So I'm going to talk a bit really on the topics on the right, a bit about data platforms and trusted research environments, some about how more data is becoming available, and particularly around COVID, quite a bit about the linkage of environmental and health data, and I'll throw in quite a lot of analyses. And today I'll also show some analyses that nobody else has seen, which will actually be produced in papers to be submitted in the next couple of weeks. So you're getting to see these before that. And then a bit around further opportunities. So if I just move on to the next one, please. So first thing I'm going to point out is actually all of what that I will talk about actually is produced by a team of people. And particularly in our world, team science is very important. So I have managed to get pictures of many of them, but not all, to sort of fit them on the slide and say the work that I'm going to present is the work of this group of people, not so much me, really. And the bottom two on the right-hand corner just are members of the public who have been particularly helpful in guiding everything we do around our work in multimorbidity and some others. So just to start off with acknowledging those, and then move on to the next slide, really. So I thought a bit about the population data linkage and why it's important. Essentially, if you look at people, there are bits about us that are captured and hidden in all sorts of places. And what we've been attempting to do is to sort of piece together the longitudinal digital traces of a person's health and well-being so that we can undertake research that makes a difference. One of the big benefits of using routine data like that is there is a relative absence of selection biases and loss to follow-up, because most recruited studies suffer quite a lot from those. And that means we can usually include groups that are hard to reach because of their ethnicities or because of their age, and various other groups that often aren't well captured in other studies. And you can then bring in data from many different sources, so the clinical data, rich in certain diagnoses, health status measurements, prescribing, etc. An area where we haven't done probably enough yet, but developing now on the sort of bringing in multi-omic and imaging data sets. Also around social care, which covers ability and disability, etc., that we're missing from health data. And then some wider data that are actually linked to education, crime, etc., that many of the data linkage systems around the world also use. An area that's underdeveloped still is this sort of bringing in the exposome from mobile and wearable technologies and that, and they offer lots to do. But these sort of things offer a lot in the way of efficiency and power, sample size calculations, and really for the scale of what we're doing, they're really low cost. We're also trying to get to a stage where we don't just have a set up a whole study to answer one question, but create platforms that can support both observation and interventional research and the assessment of population impact about all of these different interventions. And that particularly helps, I think, with the evaluation of natural experiments, and we'll talk about some of those examples. But it also extends the trial paradigm. There are all sorts of different versions of that can be enhanced, and particularly sort of adding in additional hypotheses and outcomes. And then again, there is a expanded group of analytics that's coming on, particularly around the AI community, and I'll say a little bit about that later on. So if we just go to the next slide, if I was to give a good example, I think, of why routine linkage works so well, I think that the WASCOP study in the west of Scotland is probably the best example. Now, I believe this cost £15 million to run for the 5-year follow-up, which basically showed that statins had a beneficial outcome. And then they spend £15,000 getting a 15-year follow-up to routine data, which actually changed how the cost effectiveness of those. And so you can see there on the right-hand side how the intervention was beneficial for that length of time for the outcomes that we think are important, which are A, B, C, and actually didn't have any effect on the outcomes we didn't think it would have an effect. But I think that's a really good example of what can be done. And the fact that you can extend almost any trial that's embedded in this system and produce long-term outcomes cheaply is something that's a big achievement. So again, if I just move on to the next one. So to do this, essentially, we need technology and platforms. So I just talk about the guys that I work at in Swansea have created a thing called UK CERP, UK Secure E-Research Platform. And that is a remote facility which allows privacy-protecting environments and access around the world to run a whole set of projects and programs of activity, many of which are actually put here. So we developed it for the sale of a data bank that I'll say a little bit about, but it has extended to use all of these things which are seen here on the slide. And if I go to the next one, and just to remind myself, this is also now being used in British Columbia. So I know Simon has been working with people in the Ministry of Health, and I hope that's up and running and working well. So it is a technology that's been exported and seems to be working well in very many places. And again, if I just move on. So one of the ones that we also do, and I just want to highlight, and you may also think about applying for it to access data to it. So the Medical Research Council in the UK set up an initiative about dementia research. The team that I work with, Simon, Chris Orton and others, actually run the platform for this. And what that is, it actually provides access to dozens of different cohorts and the ability to put in an application to use the data and analyze the data in relation to dementia outcomes. And it's globally available. So it's something I would encourage you to explore. And if I just put onto the next slide, particularly there are 2 publications that are worth looking at that. The one on the left in the European Journal of Epidemiology describes the platform and how it was set up. And the platform is largely consented, recruited traditional cohorts. But also within our system, we created an electronic cohort of all of the patients in Wales with dementia from different settings. And that one is published in the International Journal of Population Data Science. It is a data resource that anybody can apply to use and analyze the data, and it has recently been updated. So if I go on then again to the next one. So I'll talk a little bit now about Health Data Research UK, which is an organisation that I work for, and I lead the modernising public health research end of HDR UK. So HDR UK had about 40 or so million pounds set up by all of the funders, which are represented on the bottom of this slide, to basically really expand what we're doing in data science in the UK. And the public health science end of it, we have 4 areas of work that we're interested in. The first one is about developing these privacy-protecting total population electronic cohorts. They're largely derived from real-world data sets, and we're designing them in a way so that we can answer these complex population health questions that actually need to bring together data over time in a manner that allows us to relate exposures and interventions to outcomes and at scale, and also to reuse those. And we do have an aspiration to have covered the UK's 66 million population within 5 years of starting. And a second area of our work is about trying to embellish the traditional cohorts, which we have in the UK, very many of them, and with routine data, so we get automated follow-up and those. And part of that is one of the things that we're aiming to do at some point in time is to develop a system that allows for federated analysis of cohorts across the globe so that you can do this on an international basis. And of course, we have themes about developing innovative analytical methodologies and creating the workforce that's required to do this. So I'll just move on to the next one. So a little bit about the population data sets. I'm not going to say a lot about on the left-hand side of this slide. About 2.5 million people in the UK are participants in cohort studies. I'm a participant in one, my wife's a participant in another. So there are lots of them. And some of them are very important, like UK Biobank, many people will have come across because of the scale of it with about 500,000 people. There's some very nice ones over the years, like ALSPAC, Children of the 90s. Interestingly, you can go back to some of the earliest ones, like the Lothian bird cohorts, started in 1921. So virtually everybody in that cohort is dead. But as they put data together over time, it allows people to answer fantastic questions. A lot of interest in multi-omic cohorts and really expanding what we can do with them. And there's a new initiative starting in the UK called Population Research UK to try to increase access to all of these things. But on the right-hand side, I'll talk a bit about the routine data that's available. So all of this is becoming much more available than it was even 5 years ago, particularly GP data. And so there are lots of different initiatives which I've listed on the right-hand side where researchers can access data through different means. But the one that I'm going to talk about mostly is the one in Wales that we created, the SAIL system. And I'll particularly talk bits about the Wales multi-morbidity cohort. So if I move on again. So just a sort of infographic about the SAIL system and the sort of data sets that we have here on the population level. So we've demographic ones. ONS stands for the Office of National Statistics. So we get births and deaths files from there. We have demographic files from the health service, which is free to use by the entire population. We have lots of different health data sets, some social data sets, particularly around education and that, and disease-specific ones. And we've very many disease and screening registers, and we started work on bringing images in. And I'll go again. So some of the areas then that we're actually working on is on actually enhancing these, and particularly bringing in things like the results of all laboratory tests through a thing called the Wales Results Reporting Service, which back in 2018, we brought in more than 86 million rows of that. And that very recently has now been expanded. So effectively, we get access to every laboratory test on every person for everything. And that's unified across Wales, which is we've only really started to explore it. Another area where we really want to develop, and we've been delayed by COVID a bit about this, is about natural language processing around making sense of what's in radiology reports, laboratory reports, and clinical correspondence. Often contains much deeper data than we find elsewhere. The dispensing data by pharmacies, that's coming through. As I said, we've started to work a bit on images, but an area we want to develop a lot more, and bringing more biological data in. And we've also linked up with lots of municipalities through a thing called the Administrative Data Research Grouping, and also bringing in the census data. So if I just move on to the next one. So that's allowed us, if you like, to create many of these different clinical and population electronic cohorts. And so we've published, a number of these in different journals. They have different foci on whether they're about children or diseases like kidney disease and asthma and that, epilepsy. So, and that's helped enormously. But we're moving on a bit onto that. So if I go to the next one. So initially we started off with linking individuals, and then we came up with the idea that actually there are lots of interventions and exposures which occur at a household level. So could we move on to not just anonymizing the entire population, but I'll just go back, but anonymizing every household, and we developed a system which is reported there on the top paper in the Lancet. And we did that because it would allow us to evaluate these large-scale interventions, and particularly clustered interventions that happen at household level. And so we've conducted a number of those about housing improvement, energy efficiency, all of the things that are listed on the left-hand side of the slide there. And on the right-hand side, I said there are a number of papers. So what I'm going to do now is just go through some of those and just show you some examples, and we go next. So this one is the Housing Regeneration and Health Study. It's been published. It's there on the right-hand side. And we know there's lots of observational studies about the impact of housing on health, but not so much in the way of intervention studies. So this was an opportunity to conduct a natural evaluation. A local council was spending £200 million on turning housing into housing for social housing, really houses that were fit for people. And over that period of time, they did it. And we conducted this natural experiment on what difference that made. And at the bottom, there's the take-home message. It had a 39% reduction in cardiovascular and respiratory admissions to hospital. So that was a very important finding from a policy perspective. And another one then, if I move to the next one, is Chalice. I like this one particularly because it shows you how far academics will go to get an acronym. So Chalice basically is changes in alcohol outlet density and alcohol-related harms to population health. How torturous can you get that? But again, it was an interesting question to answer. And the question isn't really about a cross-section relationship between alcohol outlet density and measures of alcohol-related harm. It was about taking into account fluctuations around that as pubs and other places closed and open. So this is about the change in exposure and how the change in exposure relates to change in outcome. And it followed 2.5 million people in nearly 1.5 million homes. And we had to model how far they had to walk or drive to the nearest alcohol outlet. As you can see, we have no shortage of alcohol outlets, which is on the blue side, some 13 billion calculations. And it does show that changes in walking distance go up and down as the exposure goes up and down for a number of things like alcohol-related health conditions, injuries, and violent crime. And again, if I'll move on, one of the ones which we've started to work on but isn't quite reported yet is about the same concept about grey-blue space exposure and how that changes and what effects it will have on people's mental health. So it's sort of a bit of a graphic about how that is there. It's led by Sarah Rogers, who was in Swansea University but has recently moved to Liverpool. And there's a collaboration between Liverpool, Swansea, Exeter, group in Barcelona as well. And so they're looking at as when people move and therefore have a change of exposure, how does that affect their mental health? And that we can do this because we have a system that tracks all address changes over time. And therefore, when people change address, they may change exposure. And we have a grid which basically measures blue-green exposure over time. And therefore, that allows us to be able to answer these questions. So we don't quite have answers for those yet, but we'll do. And then the next one, which again is another testimony to academics and acronyms. So this one is called Beaches. And Beaches is a collaboration between Wales and Australia, two places that have fantastic beaches. But what it really is about the built environment and child health environments. And so it was one of these interesting competitions that set up between two countries, and that you had to bid in both countries to be successful. So the Medical Research Council in the UK funded, and the NHMRC funded a group largely in the University of Western Australia. And so you can see we're building up all these GIS models of the environment. And again, we'll be looking at the relationship between those models and modifiable risk factors for NCDs and obesity. And it'll utilize 5 traditional and e-cohorts. And again, if I just move on to the next one, this one is just a demonstration of the power that you get with the large numbers. Is part of our child health cohort. And what the graph that you're seeing there is the essentially survival time to first emergency admission to hospital for respiratory condition. And it looks at that by gestation. And you can see that the probability of admission, which is up to the first 5 years, it's 250 weeks. There's a massive difference by gestation. And you can even tease it apart, the difference between 30 and 49 weeks of gestation, which just helps with the power. And next. So we also do quite a bit on reproducing algorithms that have been used others. This is a work that we've done in Wales, which is to reproduce what Andy Clegg has done in England. And he's created an electronic frailty index that we find really, really helpful. So you can calculate this from 36 different variables in general practice data. And so if we look at, and it characterized people between frail, fit, moderate frail and severe frailty. And if you just purely look at their time to a hospital admission over a 4-year period, I think we have on this one, what the differences are. It's a very highly predictive variable that we now use in lots of different studies. And again, I'll move on. It also helps us to evaluate various interventions. So this one is one I quite like, which is what I call this naive policy intervention. And again, this was a funded evaluation. So the concept behind this was that if you could risk stratify the entire population into people who are likely to use the health service, and basically then you tell the general practitioners about everybody's risk, the concept was that they would fix the people at highest risk and all would be well, and fewer people would be admitted to hospital. And Helen Snooks, a colleague of ours, decided, well, this was really an intervention that needs to be tested in the trial, and persuaded them before they rolled out this national policy to run a cluster randomized trial, which we did. And lo and behold, what made a difference was actually it didn't work. In fact, it worked in the opposite direction. And the intervention groups basically had higher health service utilization rather than the way they thought it would be. But it also helps us to think about actually all of these these interventions need to be properly evaluated. And again, I'll move on. So slightly different at this stage, I was involved in a European Union project looking at routine data and its uses and how we could compare across countries. And so they were looking at the potential for novel indicators, and we dreamt up this one, thinking of, well, what would you like your life to be? So on New Year's Eve, if you're saying, what would I like to be in the next year, or what might or might not happen to me, you say, well, do you know what? I prefer if I wasn't admitted to hospital. I prefer if I didn't have to attend the emergency department. Actually, I prefer if I didn't need antibiotics or painkillers or mental health drugs. Okay. And so, well, what would that look like from a population perspective? So this is the percentage of the Welsh population who actually meet this combination of desirable features. But also we have all sorts of issues with inequalities in health. So we divided the population into fifths by deprivation. And so the least deprived are the blue group, and then the dark blue group, and the most deprived, the sort of lighter group that you can see in the bottom. So the first thing to note is that virtually none of the population, half of them meet this criteria. And secondly, we've got these massive inequalities, and those inequalities are largest, particularly in the Middle Ages. So it's a useful oversight of what happens. It's always interesting to see what does that look like in other countries, because that's not really a great experience if you think about it. And next. So I'm going to talk a bit now about multiple long-term conditions. How am I doing time-wise? I might need to zip along.
You're fine so far.
Fine so far. Okay.
Yeah.
So multimorbidity, multiple long-term conditions, creating new data assets. So if I move on. So one of the things within Health Data Research UK, we had 5 or 6 different geographical sites. And what we then decided to do, they were all set up to do slightly different things, but could we do something in common? And we decided a project on multimorbidity using routine data would be very helpful. And so then we set up, essentially, if you can see, there are groups of people from very many different universities who are working on this. So data from Scotland, Northern Ireland, Wales. Calibre is essentially a set of data held by UCL in London from one of the GP suppliers, and there's some in Leicester and another part of London. The idea, we would try to create this cohort of 20 million people and harmonise so that we can conduct research into it. And next slide. So one part of it then was creating the Wales bit. And actually, I think today or yesterday, the protocol was published. So we brought together this team. And what I wanted to just point out particularly about it, this is a multi-university team. And it's great to be able to bring together a larger group of people. The 2 people in red that are highlighted there are members of the public that are helping us basically steer what we're doing and ensure that we answer questions that are relevant to them. So if I go on to the next one, just a little bit about it. So it's essentially 20-year follow-up from all of the people we know about in Wales from 2000, and we followed them up for 20 years till the end of 2019. There's 2.9 million people in it. Some 46 million years of follow-up. About 60% of them are still around at 20 years, and about 18%, or over 500,000, have died. And then we're putting various phenotypes from that are well known used in the bottom there. So some little numbers on the right-hand side, but we'll just move on again. Next. Yeah, so basically what we're doing this for is to answer all these questions about, well, what's the prevalence? How is it changing of time? What about clusters? Actually, do we have clusters that occur not just more frequently, but less frequency? What can we tell about biological, psychological, social determinants of it? How does it change over the life course? What do we know about the determinants? Which ones are associated with poor health and service outcomes? And then do they differ by various categories? And so again, we move on. So just to show you, this is the sort of survival by our age groups, obviously with the youngest ones on the top and the oldest groups then at the bottom. Time is in days here. And so basically just shows that actually we have quite a lot of mortality outcomes across all age groups, and therefore the power to be able to distinguish things. Now, when we bring this together with the other cohorts that have been developed, it'll be even more powerful because it should be 5 or 6 times as large as that. And then next. So one of the things that we have quite a significant research interest into is on socioeconomic inequalities in health. So WIMD is just the Welsh Index of Multiple Deprivation. So here we've just sort of, for example, pulled out the survival curves in this one for people to start in their 40s on the left-hand side or in their 60s on the right-hand side. And again, the first thing just to point out is these are huge inequalities in health. I mean, to be honest with you, they're shameful. And so it's a big area that we need to study as to exactly why we're having this and what interventions make a difference. And again, so one of the things then is how many cases would we have in the various conditions, and is there enough power to be able to detect? So this one particularly just looks at one of the groupings that we have. So all the conditions that create the Elix-Hauer comorbidity index. And so basically the diagram just shows you the numbers we have. On the bottom, it shows the numbers we have in various combinations, and therefore the ability of people to be able to explore the data and decide whether there are enough numbers to be able to answer the questions. And again, and so, and again, if we just look at how to demonstrate how common the various conditions are at different age groups, we basically put the people in their 20s and what sort of conditions they have on the left-hand side, and then take people in their 70s on the right-hand side, and you can see the sort of conditions. And obviously, the individual and multiple morbidities, that they vary very considerably over time. So big differences, as you would expect. But so then this is one of the interesting things. So if you start to study multiple morbidities, you say, well, you could combine them. And how many combinations is it possible to make? So the Charlson index is about 13 conditions. Elix-Hauer is 26. If we do move to the global burden of disease, then there's nearly 360. Okay. So basically, what possible number of disease sets can you get? Well, 8,000 in the first one, 67 million for the second one, and then a very, very large number on the right-hand side, more than the people that exist. And the calculation time to look at these things becomes enormous. So that's actually a challenge which two of the people working with us are looking at, James and Rowena. And next. So they're looking at all sorts of exploring different analytical tools. And this is sort of just an example of some of their work, and they're thinking about this in adapting a thing called hyper networks, which I have to say I only barely understand, and about how that you can actually have a sort of this almost like three-dimensional image of which diseases and groups of diseases are related to each other. So I find it quite helpful to look at, so you can see that on the left-hand side around peptic ulcer and liver disease, there's clearly relationships with that. But actually, you could study this in different ways to help refine the questions, because it's not possible to look at all the combinations that are there. And again, so one of the issues around this is there are all sorts of different analyses that are possible. That will depend on the purpose, whether you want to look at clusters or determinants, trajectories, etc. To make sense of it, you need to combine breadth and depth of data over long periods of time. One of the things I haven't really got into it yet, but actually defining the start, end, and duration of conditions is really complex using routine data. It sounds like it should be obvious, but it's not. It's very easy to create these pseudo clusters due to phenotypic depths. So if you basically break down your cancers into smaller and smaller groups, etc., you'll find they're related, and it produces a thing called pseudoclusters. We also find that the expertise to do this is often overlooked or underfunded. A lot of the funders don't really understand the depth that needs to be gone into. And of course, you need these trusted research environments that help us. And next. So turning to a bit towards the end now on some of our COVID research, and just point out some of the publications. There's one we've been involved in Q-COVID, which is looking at essentially how to risk stratify the population and the underlying risks from diseases and ethnicity. And then we've created another platform in Wales on the right-hand side about how we're bringing all of these data together and actually using them to answer questions very quickly for policymakers. So if I go down onto the next slide now. So we did apply and we got a grant to create this con-COVID platform, which is about enhanced population surveillance and intervention. So we have the cohort includes all of the people on the 1st of January 2020, which are known to the NHS and followed up to present. And we have a counterfactual one for the years beforehand. We are able to anonymize everybody. We've created cluster groupings for residents through these things, residential ALFs. And we've now created them for schools versus a thing called SALFs, and we have one for care homes, etc. So I'll just show you some of what we're up to. Next. Well, one of the things we do, which we track a lot, and this is a slightly old slide, is some of the indirect effects of the pandemic on the general population. So if we look at the green here, basically shows you the volume that we have of surgical activity in 2019 in the blue and 2020 in the green. And you can see slightly elevated bits. We're doing a little bit better in the early part of the years. Along comes the pandemic, and we've had fairly massive effects of reduced surgical activity. And then the next one. This is one which just looks at something a bit different. These are people undergoing cancer therapy in hospital. Again, we're substantially down on that. And then the next. Right, and just stop there for 2 seconds. So basically, we're tracking these people now who haven't been treated, and over time, we'll be looking at how this affects their outcomes. I'm sure this is an activity that everybody's doing. One of the things that allowed us to do is also track what's been happening in our care homes through the care home data linkage. So this is, again, it just shows simple survival by year. And you can see for the 4 years before 2020, we more or less have the same sort of graph with survival for people in care homes. And then along comes 2020 in green and this massive increase in deaths that we've care homes. I mean, I don't know whether this is something that's affected your community as much as ours. We've been having pretty much of a disaster with that. And again, so this is the first time anybody has seen these now. One of the other things we're looking at is how has the pandemic affected healthcare workers? So we were able to get all of the healthcare worker data anonymized and linked into the system. And this is looking at the risk of infection through PCRs, swab tests in the various categories of work. So I've just highlighted the group in the middle. So you can see elevated and significant odds ratios for foundation year doctors. They are our junior doctors, healthcare support workers, and hospital nurses. So our system to protect them hasn't worked very well. If it did, they wouldn't have elevated risks like they currently have. And we have managed to infect quite a high proportion of some of those staff groups. And I'll go on to the next one. And so the next one, which is the one I think I'm just about to finish with, really is about what's happening with schools and teachers and pupils. So again, we have this system that now is allowing us to track infections in teachers and in staff. On the right hand in the graph, you can see there the actual numbers of students and staff who've been affected. You see there are lots of them. It's, particularly has grown in the autumn. So December was pretty much of a disaster. And we've then carried out various adjustments for age and sex, the type of school and school size, and potential exposures through contacts at home, within the school, or within these extended homeschool bubbles. Some of the data is a year behind, and because of that, pupils will have moved school. So in the analysis, then we've chucked out the 11 and 18-year-olds. One group will be changing from primary to secondary school, and the other will be leaving school. So they would make a difference to the analysis. And I'll go just next one. So a little bit just about the background. We have this school workforce annual census, SWAC, which basically is the data on all the staff in the schools. And then we have the educational data for Wales, which is the data on the pupils. They are managed by different systems. And so one of the things that we had to try to work out was, and they've called the schools different names. So actually making sure that you can link the staff to the pupils in the school. There's quite a lot of work being done, and it's about 98% accurate in what we've done. And you can see the numbers on the left-hand side of staff, some 50,000 and nearly 250,000 pupils in these analyses. And then I go into the next one. So this then is a piece of work which is done automatically for every person in this system. So what we're looking for is we take in all of the people, and then we see whether or not there has been a case or the number of cases in the household, and whether there's not been a number of cases or a number of cases in the school bubble they're in, and we follow them up over time. And then that allows us essentially on the right-hand side, count the number of cases which are in the school bubble, the SALF, or in the residential household bubble, the RALF. And then use that for the analysis, which I'll come up to next. So here we have the results to the using all of the infection data up until the end of December 2020. And so you can, on the left-hand side, you can see is, first thing to remember is not everybody gets tested in this. So our system largely looks for testing symptomatic people and testing some contacts. So only 15,000 of the 50,000 staff have been tested, and you can see the number of positive tests. And the same goes with pupils. So bear that in mind. And then the blue one basically tells us what the odds ratio for infection are relative to exposure. So 25. So basically, if you have a case within your household, the likelihood of a case essentially within the teaching staff goes up 25-fold per increase. So it's a massive odds ratio. What we then have 0.93 for the staff case count is that we don't seem to have, if you've got another staff member infected in the school, that doesn't seem to transfer to other staff members. And the same with infections in the pupils, not transferring. And if I go on the other side, you can see I'll just go back to that one, yeah. Since you have big elevated odds ratios for pupils being infected if the member of their household is infected, the top one, staff not passing things on to them much, but pupils in the same year, 1.14 per infected pupil. So that's quite substantial. So that basically tells us quite a lot. On the bottom one, it's about also if there has been a case in the household of school members, but not in the staff member or in the pupil, we're still seeing an elevated risk of infection. And the reason for the bottom end of it is probably because there are lots of asymptomatic infections. And so it's possible to actually increase the risk even without being an obvious source. And then I'll go on to the next one. All right. So here basically is the proportion of staff and pupils that have a possible route of transmission explained. So if you just look at the neither on them, actually, so for over 90%, we know of other cases of staff or pupils who've had infection. This is not saying, of course, that they got them that way, but there's a plausible route to doing so. And again, if I just come down to next. So I basically just put back up that list of things of what's next if we go there. We'd like to do a lot more on the laboratory results and the NLP and bringing the other ones together. So we think they're areas that we need to pick up when we're slightly less busy with COVID. And if I go to my final slide, which is this one, just to say we're only able to do this because of the using patient data that we've been given privileged as access to. So we'd like to just thank all of those people whose data that we use that make a difference and make us able to answer those questions. And I'll stop there.